Let's study about raised intracranial pressure. Intracranial pressure is the pressure of CSF within the cranium. Normally, the intracranial pressure is pulsatile and less than 5 mmHg in newborns, 6 to 15 mmHg in infants, 10 to 15 mmHg in older children. Raised intracranial pressure means the pressure more than 40 mmHg. What is the pathophysiology of raised intracranial pressure? Due to raised intracranial pressure, there will be decreased in cerebral blood flow and herniation of brain tissue. Normally, the cerebral blood flow is 50 ml per 100 gram of brain tissue per minute. It depends on cerebral perfusion pressure, which is the difference between mean arterial pressure and intracranial pressure. So, if the intracranial pressure will increase, then the cerebral perfusion pressure will decrease, hence, cerebral blood flow will decrease. Myogenic, metabolic, and neurogenic autoregulatory mechanism help maintain cerebral blood flow. Decrease in cerebral blood flow, that is less than 40%, will lead to ischemia, neuronal death, and cerebral edema. If there is further increase in intracranial pressure, then there will be bilateral cortical dysfunction and coma. What are the causes of raised intracranial pressure? First is hydrocephalus, next is CNS infection, next is intracranial hemorrhage, next is space occupying lesions such as tumor, granulomas, and abscesses. Next is metabolic causes like Ray's syndrome, inborn error of metabolism, and acute hepatic failure. Next is arterial and venous stroke, hypertensive and encephalopathy, and last is idiopathic. What are the clinical features? The symptoms are headache, vomiting, visual disturbances, processing to focal neurological deficits, and last is coma. If there is raised intracranial pressure before closure of sutures, then there will be increase in head size and hydrocephalus, which will present as bilateral sunsetting of eyes. There will be tense bulging of anterior fontanelle, hypertension, and bradycardia. If there is increased intracranial pressure, there will be sixth cranial nerve palsy, which will represent as false localizing sign, squint, and diplopia. In older patients, sutures are closed, so if there is raised intracranial pressure, when we will percuss the skull, there will be sound of cracked port, and that is called as positive McEwen sign. There is herniation of brain tissue and compression of brain stem, coma, and death. What is the management? We will measure the intracranial pressure by invasive method, and it should be done with strict aseptic precautions and done in intensive care settings. If the patient is having coagulopathies, then we will not do this invasive test for measurement of intracranial pressure. Next management is we will raise the head end by 30 degree and keep the head in midline. We will hyperventilate to maintain PCO2 at 30 to 35 mmHg. We will administer mannitol at 0.25 to 1 gram per kg. And if it is 20% solution, then 1.25 to 5 ml per kg as IV bolus, and repeat every 8 hours for 48 to 72 hours. We will also administer hypertonic saline, 3% of saline at 0.1 to 1 ml per kg per hour to maintain the serum sodium at 145 to 155 milliequivalent per liter. We can administer IV furosemide at 1 to 2 mg per kg per dose. We will switch to oral acetazolamide or glycerol when stable. Consider corticosteroids for vasogenic edema and consider decompressive craniectomy.